Hey guys, in this video we'll be learning about diuretics. Okay, so what we're going to learn about diuretics today is definition of diuretics, classification, all the pharmacological aspects of high ceiling diuretics and weak or adjunctive diuretics, and the summary of everything. Okay, so now what are diuretics? Diuretics, that are also called as natriuretics, are a group of drugs that cause a net loss of sodium and water from the body through the urine. Okay. With this in knowledge, let's now see the classification of diuretics. Diuretics are classified as high ceiling diuretics, medium efficacy diuretics, weak or adjunctive diuretics. In this video, we'll be mainly learning about high ceiling diuretics and weak or adjunctive diuretics. Okay. High ceiling diuretics. These are also called as loop diuretics or high efficacy diuretics. The examples are sulfonyl derivatives. Under sulfonyl derivatives, furosemide, bumetanide, torsemide are the examples. Okay. Among these group of drugs or among these drugs, furosemide is studied as the prototype drug. Okay. Now let's learn about the pharmacological aspects of this particular prototype drug. Okay. So the site of action, it's on the luminal side of the ascending loop of Henle. Luminal side of the membrane in the ascending loop of Henle. Now let's see the mechanism of action. It mainly inhibits the sodium potassium 2-chloride cotransporter. What does this cotransporter mean? It means that there is a cotransporter molecule that transports sodium potassium 2-chloride ions simultaneously across the cell membrane from one side to the other. Okay. The other actions include they weakly inhibit carbonic anhydrase enzyme in the proximal tubule. Many of you might be wondering what is carbonic anhydrase? It is an enzyme that will be dealing under a different group of drug. Okay. For now, let's remember high ceiling diuretics inhibits sodium, potassium, and 2-chloride transporter. As you all can see, this is the schematic representation of mechanism of action of loop diuretics. So loop diuretics, this is the luminal side of the ascending loop of Henle, and this is the interstitial medulla, interstitial fluid medulla. Okay. In between, we see this as the cells that line the luminal side of the ascending loop of Henle. On the luminal side, we can see there is a cotransporter molecule that is being inhibited. Okay, it is being what? It is being inhibited. Okay, it mainly in this cotransporter molecule normally transports sodium, potassium, and 2-chloride ions across the cell membrane. Okay. So in this picture again, we see the mechanism of action of furosemide. Okay. So there is this cotransporter molecule which cotransports sodium, potassium, 2-chloride ions. Okay. When this cotransporter molecule is being inhibited, it means that these ions that are sodium, chloride, and potassium, they're not being reabsorbed. When these ions are not being reabsorbed, it means that they are excreted through urine. When they're excreted through urine, they also excrete the water associated with these ions. Thus, there is net loss of ions and water. I hope it's all clear for you guys. Now, let's study about the pharmacokinetics of high ceiling diuretics or loop diuretics. They are rapidly absorbed orally. Their bioavailability is around 60%. They are highly bound to plasma proteins and low lipid solubility is seen. The average half-life of it is around 1 to 2 hours. They are excreted both in urine as well as in bile. Now we'll see about uses and indications of loop diuretics. Edema, irrespective of the etiology of edema, may it be cardiac, hepatic or renal. These group of drugs are used. They are highly preferred in congestive heart failure and chronic renal failure. Acute pulmonary edema, where acute left ventricular failure is seen following myocardial infarction. Hypertension, that is hypertensive emergencies, renal insufficiency and congestive heart failure. During blood transfusions to prevent the volume overload. And at last, during hypercalcemic states, these drugs are used. The adverse effects of these drugs include hypokalemia, with its symptoms being fatigue, muscular weakness, cardiac arrhythmias. Okay, these are cardiac arrhythmias and fatigue. Okay, and other electrolyte imbalances that can happen due to an adverse effect of these group of drugs are hypocalcemia, hyponatremia, hypomagnesemia. This really suggests that there is excess excretion of ions through the urine. So that makes it up for the adverse effects. Next, ototoxicity leading to vertigo, deafness and tinnitus. So here we see uh, vertigo, okay, hypersensitivity reactions like skin rashes, eosinophilia and photosensitivity and other allergic reactions. Okay, and then other metabolic disturbances like hyperglycemia, hyperuricemia, hyperlipidemia. So this is a picture for hyperglycemia. It's very common, hyperglycemia. Okay, next. As future medical practitioners, it's very important for us to be aware of all possible drug interactions related to the drugs that we prescribe. So now we'll see the drug interactions of high ceiling diuretics with furosemide being the prototype drug. Furosemide with digoxin precipitates digoxin toxicity. So why do you think this happens? This happens mainly because of increased excretion of potassium leading to hypokalemia. Okay. Next, furosemide with aminoglycosides. We know furosemide and aminoglycosides both are ototoxic. Together, they enhance the ototoxicity. Okay. Next, furosemide with non-steroidal anti-inflammatory drugs. Chronic use of NSAIDs leads to sodium and water retention. This diminishes the antihypertensive effect. Furosemide with lithium leads to lithium toxicity. Furosemide with amiloride has a synergistic effect. Amiloride is one of the other diuretic drugs that we are going to read under weak or adjunctive diuretics very shortly. Okay, weak or adjunctive diuretics can be classified as carbonic anhydrase inhibitor with its example acetazolamide, potassium-sparing diuretics with its examples of two categories, that is aldosterone antagonist being spironolactone and inhibitors of renal epithelial sodium channels being amiloride. The last one is osmotic diuretics, examples being mannitol, isosorbide and glycerol. So I hope you all remember in the previous slide we spoke about amiloride. Now firstly we'll be speaking about carbonic anhydrase inhibitor with its example acetazolamide. All right. So I hope you all remember a few minutes back I did speak about carbonic anhydrase inhibitor. So now let's see the site of action. The site of action of this enzyme is all the sites wherever it is present. So this enzyme carbonic anhydrase is present in renal tubular cells of proximal convoluted tubule, gastric mucosa, ciliary body of eye. This is very important. Okay, brain and RBC. Pharmacokinetics is it is very well absorbed orally and excreted unchanged in urine. The duration of action is pretty long. It's about 8 to 12 hours. Under mechanism of action of acetazolamide, let's look into the action in the renal system. Its action in renal system. So basically, this tubular fluid, this is the tubular cell, and this is the interstitium or the blood. Okay. So what happens in the tubular fluid is, firstly, sodium bicarbonate dissociates to form sodium ion and bicarbonate ion. Sodium ion is exchanged with sodium ion is exchanged with a hydrogen ion. Okay, this hydrogen ion combines with bicarbonate ion to form carbonic acid. This carbonic acid, with the help of the enzyme or under the influence of the enzyme, carbonic anhydrase splits or dissociates to form water and carbon dioxide. This water and carbon dioxide diffuses into the tubular cell, okay, to form carbonic acid again under the influence of carbonic anhydrase and later dissociate into bicarbonate and hydrogen ion. Okay, this is all these steps are physiologically involved in the acidification of urine. So what carbonic anhydrase inhibitors does is it inhibits the action of carbonic anhydrase. That means the acidification of urine has failed, right? So now we can use carbonic anhydrase inhibitors to alkalinize the urine. I hope you all understood the diagram. Next, pharmacological actions of acetazolamide. So there are mainly two sites, renal and extrarenal. So firstly, let's learn about renal actions. It mainly acts as a low efficacy diuretic. Okay. The extrarenal actions involved are in the eye, where it reduces the intraocular tension by reduced production of aqueous humor. Okay. And then in the GIT, it decreases the HCl production and also pancreatic sodium bicarbonate. Okay, and now it's also used in sedation and elevation of seizure threshold by raised carbon dioxide in brain and lowering the pH. Okay, uses and indications of acetazolamide. It is used to alkalinize the urine during acidic drug poisoning. We already studied about alkalinize the urine, how acetazolamide alkalinizes the urine. With the diagram, we have already learned it. Okay, this during acidic drug poisoning. Okay, the extrarenal sites where the acetazolamide is used is in the eye for glaucoma. It decreases the intraocular pressure by preventing the formation of aqueous humor. This is again based on the fact that there is carbonic anhydrase enzyme present in the eye, which is responsible for the formation of aqueous humor. Okay, so when carbonic anhydrase is inhibited, there is reduced production of aqueous humor, thus reducing the intraocular pressure in the eye. It is used during acute mountain sickness. It's also called as altitude sickness or high altitude sickness. Okay, acute mountain sickness, it gives symptomatic relief. Okay, it's because of the change in the altitude. Okay, mainly acetazolamide is used as a prophylaxis by mountain climbers. Okay, so it is used as a prophylaxis to prevent the possible symptoms of acute mountain sickness or high altitude sickness. Other uses and indications of carbonic anhydrase inhibitor. Okay, miscellaneous, being an adjuvant in epilepsy. Okay, now the adverse effects are hypersensitivity reactions, carbonic metabolic acidosis, renal stones, and paresthesia. Okay, so contradictions of carbonic anhydrase inhibitors, mainly liver diseases, which can lead to hepatic coma. Okay, if you use in patients with liver diseases. Okay, and if you use carbonic anhydrase inhibitors in patients with COPD, it will worsen to due to metabolic acidosis. I hope you all know what is COPD. It stands for chronic obstructive pulmonary disorder or chronic obstructive pulmonary disease. Okay. Now we'll move on to potassium sparing diuretics, mainly being aldosterone antagonist, the first category, among them spironolactone and eplerenone. There are the examples. The second category being inhibitors of renal epithelial sodium channel, being amiloride as an example. Okay, the site of action is distal convoluted tubule and collecting duct. Okay, the pharmacokinetics of spironolactone. 75% of bioavailability is seen when it is administered orally. Okay, highly plasma protein bound and is completely metabolized in liver, whereas amiloride, it only takes 1/4 of the oral dose is absorbed, not bound to plasma protein. Half-life is around 20 hours and the duration of action is very long. Okay, next. Now let's learn about mechanism of action of spironolactone. In a nutshell, aldosterone binds with mineralocorticoid protein. Okay, this to form aldosterone induced protein. Okay, aldosterone binds with mineralocorticoid receptor to form aldosterone induced protein. Okay, uh, which promotes these aldosterone induced proteins promotes sodium reabsorption and potassium secretion. Okay, spironolactone binds to mineralocorticoid receptor by acting as an antagonist to aldosterone. Okay, this inhibits the formation of AIP. Okay, thus it spares the potassium ion Also, it excretes the sodium ion by preventing the reabsorption. Okay, it's very clear. This is, in simple terms, spironolactone is an antagonist. Aldosterone is an agonist to MR. MR is mineralocorticoid receptor. Okay, I hope it's all clear for you guys. In this picture, let's learn about the mechanism of action of amyloride. Okay, we've already seen the mechanism of action of spironolactone. I hope it's all clear for you guys. Now about amyloride, a sodium ion enters the renal epithelial cell down its electrochemical gradient. Okay, this electrochemical gradient that I'm talking about is being generated by the sodium potassium ATPase pump that is present on the basolateral membrane of the cell. Okay, as soon as the sodium ion enters the cell, a potassium ion is being secreted into the lumen and thus being excreted. What amyloride does is it inhibits the sodium channel that is present on the renal epithelial cells directly, thus inhibiting the transport of sodium into the cell. So when this is being inhibited, there is no secretion of potassium ions into the lumen, thus potassium is being spared. I hope it's all clear for you guys. Uses and indications of spironolactone. It is used in edematous conditions associated with secondary hyperaldosteronism. Okay, in cases of congestive cardiac failure, this is used because it can prevent hypokalemia. Okay, and it is used synergistic combination with loop diuretics. Okay, and it is also used in the treatment of Conn's syndrome. What is Conn's syndrome? It is resistant hypertension due to primary hyperaldosteronism. Okay, and it is also used to counteract potassium loss due to loop diuretics and thiazides. Okay, drug interactions of spironolactone. If they're given together with potassium supplements, it can cause hyperkalemia. And aspirin blocks its action. If only spironolactone with aspirin is given, it blocks its action. Okay, and it increases the plasma digoxin concentration. If plasma digoxin concentration is increased, there is easy digoxin toxicity. Okay, that is a possibility. Adverse effects of spironolactone. Series of adverse effects include hyperkalemia and it aggravates peptic ulcer. Okay, these are the serious side effects. And hormonal side effects include gynecomastia and erectile dysfunction in males, and females show menstrual irregularities and breast tenderness. Okay, these are the hormonal side effects that is seen as an adverse effect of spironolactone. Uses and indications of amyloride. Okay, used in combination with loop diuretics and thiazides to treat hypertension. Okay, treatment of lithium-induced nephrogenic diabetes insipidus. Improves mucociliary clearance in patients with cystic fibrosis. Okay, the adverse effects of amylorides. There are no serious side effects. Usually, the usual side effects include nausea, diarrhea, headache, dizziness, muscle cramps. Now, let's learn about the last group of diuretics for this video. Okay, they are osmotic diuretics. Okay, examples being mannitol. Pharmacokinetics involved. They are administered through IV route, pharmacologically inert, freely filtered in the glomerulus, and half-life is about half an hour to 1.5 hour. Okay, site of action it's mainly on proximal convoluted tubule and loop of Henle. Okay, so what is the mechanism of action of mannitol? Mainly, it draws the water from intracellular compartment to extracellular fluid. Okay, and then this expands the extracellular fluid volume. So When the extracellular fluid volume increases, there is increased renal blood flow and there is increased glomerular filtration rate. This results in increased medullary blood flow and also increased osmolality of fluid. Osmolality is nothing but the concentration of solutes in kg of water or in kg of the solvent. Okay. When the medullary blood flow increases, there is decrease in hypertonicity of the medulla. Why there is decrease in hypertonicity? It's because of washing off phenomenon. Okay, and then this inhibits the reabsorption of water. All this together, both of them together, result in inhibition of reabsorption of water and also decrease in passive reabsorption of NaCl. When there is reabsorption of water, there is also reabsorption of NaCl. When there is no reabsorption of water, there is also no passive reabsorption of NaCl. So that's why it's reduced. Okay, that's how it works. This is the mechanism of action of mannitol. Okay. Uses and indications of mannitol. It is used to reduce the intracranial tension. This is one of the most important clinical application of mannitol. Okay. Mannitol is normally used in craniotomies. Craniotomies are surgeries done on brain by removing or opening the cranium. Okay. So it also helps in reducing intraocular pressure in congestive glaucoma. Congestive glaucoma, intraocular pressure of eye. Okay. To maintain the osmolality of ECF after dialysis. Okay, used to prevent acute renal shutdown in cases of shock and in major surgeries. Okay, in major surgeries and in shock, it prevents acute renal shutdown. Okay, serious side effects include it can lead to pulmonary edema. Okay, other serious side effects can include headache, nausea, and vomiting. Okay, these are common side effects that can be seen. So now we we are at the end of the video. Let's summarize what we learned from the beginning of this video. Okay, loop diuretics are also called high ceiling diuretics. They act on ascending limb of loop of Henle. Okay, what does it inhibit? It inhibits sodium potassium 2 chloride channel or co-transporter. Okay, the efficacy is high. And acetazolamide. Acetazolamide is nothing but it is a weak or low efficacy diuretic. Okay, it acts on the proximal convoluted tubule. It inhibits the carbonic anhydrase enzyme. Also, it is also called as carbonic anhydrase inhibitor. Alright, potassium sparing diuretics. There are two categories: aldosterone antagonists and sodium channel inhibitors. Aldosterone antagonist is spironolactone, sodium channel inhibitor is amiloride, and then it mainly acts on distal convoluted tubule and collecting duct. The efficacy is low. Osmotic diuretics. Osmotic diuretics, the main mechanism of action is through osmotic effect. Okay, and then the site of action is mainly proximal convoluted tubule and loop of Henle. Okay, the efficacy of osmotic diuretics is very high. Okay, I hope everyone's understood the topic. Thank you all.